Welcome. I'm Andrew Baird. I'm a GP in Elwood. I'm a tutor in professional practice at the University of Melbourne Medical School, and I'm also your host for an evening with Brett Sutton. I would like to begin by acknowledging that I am on the traditional land of the Yellowkit Weelam clan of the Boon Wurrung people. I also acknowledge the traditional custodians of the lands from which you are meeting. I pay my respects to elders, past, present and emerging, and I extend that respect to Aboriginal and Torres Strait Islander peoples who are here with us today. I acknowledge that sovereignty has never been ceded. I'm thrilled to welcome Professor Brett Sutton to our webinar, and I thank Professor Sutton for accepting our request to meet with us. And I'm delighted to welcome you, University of Melbourne medical students, and tonight's panelists, your chair, Lisa Huang, Olivia, Raymond, Ross, and we have Ryan too. This is your webinar. I'm also very pleased to welcome Professor Steve Trumbull and colleagues from the Department of Medical Education. So just a bit of brief background to our webinar. A short list has been drawn up from the questions that you kindly submitted, and there are three themes for this webinar: Professor Sutton's early career, Professor Sutton's current role as Chief Health Officer, and well-being. This webinar is not about the pandemic or SARS-CoV-2 as the principal themes, although it's appropriate and inevitable that we will be covering those subjects in our discussion. We're using the Zoom poll feature, which will enable you to vote for the questions which you would like to be asked to Professor Sutton. Throughout the webinar, you can use the Zoom chat feature to send to the panel your questions and comments about the discussion. The questions and comments will then be relayed to the audience, provided they're appropriate and named. So nothing anonymous and nothing inappropriate, please. We're not using the Q&A and reactions features of Zoom. So if you're familiar with those, they won't work, so don't try. The webinar is being streamed live on the Department of Medical Education Facebook page, and it is also being recorded, and the recording will be available on the Department of Medical Education Facebook page tomorrow. Unlike many webinars and Zoom meetings that you attend, there is no evaluation, so you've got freedom from evaluation with this session. So I now wish to ask Professor Sutton, Lisa, Ryan, Olivia, Raymond and Ross to introduce themselves and to introduce their conversation. So Lisa.
Thanks, Andrew. Hi everyone, my name is Lisa. I'm an MD4 based at the Western, and I'm your current president. So as Andrew alluded to, we will now run our first poll for the session, which are questions centered on Professor Sutton's early career before his current role as the Chief Health Officer. So students in the Zoom audience, please choose the question that you would like answered the most. And in the meantime, I will let Professor Sutton introduce himself.
Thank you so much. I'm going to close a window that's asking me a question. Look, thank you so much for the invitation, Andrew, and everyone. It's a real privilege to be able to link up with everyone, and fantastic to see 539 people online. I'm sure the interest is great because of coronavirus, but I hope I can offer some insights and some interest beyond just this year. It's a great pleasure to be here. Thank you.
Thanks so much, Brett. I'll let the other panelists introduce themselves. So Ryan.
Hi, I'm Ryan. I'm an MD student and I'm currently studying a Master of Public Health.
Hey, hello, I'm Ross. I'm currently a third-year student located in the Rural Clinical School.
Hello, I'm Raymond. I'm a second-year med student at the Western Hospital.
Hi, I'm Olivia, and I'm one of the MD1 representatives this year.
Thank you, everyone. So it looks like the students have finalised their preferences in our poll. Our most voted question to kick off the night is about your journey following your graduation from the Melbourne Medical School. So Professor Sutton, you've had quite an interesting career path, to say the least. So could you tell us a bit about what you decided to do after you left medical school before working at the Department of Health and Human Services?
Sure, and please call me Brett. Look, in a way, I've had three careers in coming to this point in time. I kind of frame my first career as being emergency medicine or emergency departments, and I fell into it more by default than anything else. And I think that's a reasonable reflection for everyone, that you don't have to have it set in stone. You don't have to have found your passion point as you step out of medical school on that last day, or step out of exams and go for your well-deserved summer holiday. I knew what I didn't want to do, and I guess there are a number of specialties that weren't appealing to me. And I knew that emergency medicine was an opportunity to kind of locum, move around and just explore what it might be to be in different settings. And I kind of did that for 10 years in one way or another. I worked in Blacktown Hospital in New South Wales and Campbelltown Hospital. I spent some time in Bendigo Base Hospital Emergency Department as a medical student, and I'd gone up to Albury-Wodonga as a medical student. And then I basically put my hand up to do ED in Box Hill Hospital. From there, I went to Northwestern Tasmania and worked in Northwest Regional Hospital. And that became a much steadier kind of emergency department career, because I was offered a position first as a medical registrar, but then just as an ED kind of senior, and then offered a position of deputy director of the ED. And that kind of became my family. It was a small emergency department. It didn't have all of the issues of bed block and ambulance ramping back in the day. And I really loved it. So I spent 5 years there in that role, essentially. I then had some time where I went to Afghanistan while I was there. I'd previously been to Afghanistan very early on, 1996, and knew that I wanted to do MSF again. But it was really that 10 years where I was in the emergency departments. But going to Afghanistan the second time, I think it was pretty clear to me that I was transitioning out of emergency. 10 years is a pretty long time to do that kind of high-paced clinical work. And I did reflect on the fact that I'd never achieved my FACEM. I'd never gone for it. So I didn't become an emergency physician. So I kind of hadn't locked myself in the way that some other specialist emergency physicians might do in their career. And I thought, 20, 30, 40 years of emergency might be a bit long for me. And if you look at emergency physicians 20 years in, they're kind of doing less than 30% clinical work, and the rest of their time is administrative or tutoring. So it's not one to keep the pace up for 40 years straight. And I really loved the international work that I got a taste of in 1996 and again in 2003. And so going back to Afghanistan, even though I came back to Melbourne shortly after that trip, I kind of knew that I wouldn't be returning to emergency. I did some locums again, but I also met my now wife in Afghanistan. She was working for a humanitarian agency, working with Afghan refugees returning from Iran. And then we did a whole bunch of deployments together. So Horn of Africa, East Timor, we went to Geneva, and then having 5 years away from Australia and emergency medicine, I knew that there was really no going back. I'd have to retrain, and I'd have to have that real passion again to get back into it. But I love that humanitarian career and working in the development sector as well, internationally. Absolutely love the infectious disease and tropical medicine components of being in Afghanistan and Ethiopia and refugee camps there and in northern Kenya. And the interesting thing about the last 18 months of that 5 years away was being in East Timor. It was much more development focused, and it was much more focused on health system strengthening. So I really worked hand in glove with their Ministry of Health and the kind of senior leads in that area, and we worked on child survival interventions, so increasing immunisation rates, integrated management of childhood illness, nutrition, exclusive breastfeeding, neonatal care, health promotion. So all of those things were really embedding some improvements in the long term. And in that time, the infant mortality in East Timor over a 5-year period halved. And so that's 3,000 kids under 5 alive every year that wouldn't have otherwise been alive. And so that was a real reflection for me about what you can do as a sustainable intervention that makes a huge difference at a population level. 3,000 lives saved, and it wasn't all me, of course. It wasn't all my organisation or the project, but we played a really significant role, and it got me thinking about public health. And so when I returned to Australia, I did some remote working for that Timor project. But I also started looking at public health work without really understanding what it looked like in Victoria, in Australia, and saw a position within government, which I'd never really done. I'd never really been attracted to being a bureaucrat, but I did put my hand up for it. I turned down the first job because I was a bit horrified by the prospect of being a bureaucrat, but I did think of it some more, and the then Chief Health Officer reached out to me. She was the Assistant Director for Communicable Diseases, later Chief Health Officer Rosemary Lester, and she talked to me about being a team leader within the communicable disease team. And that's really been my starting point in the Department of Health. Loved communicable disease, infectious disease, outbreak follow-up, and kind of worked my way through there, kind of getting across all of the outbreak responses for all of our notifiable diseases, becoming the Deputy Chief Health Officer for communicable disease. And again, not really thinking about being the Chief Health Officer until much more recently, and thinking what a fantastic challenge it would be. Little did I know. And also going beyond the communicable disease components of health protection or public health to the broader aspects, which are environmental health and food safety in the health protection space. And of course, also the much broader aspects of human health and wellbeing that are not so much a part of the Chief Health Officer's role, but I'm not disconnected from them either. And so that's the journey to this point.
Wow, what a journey. So you started off in the emergency department and worked there for a couple of years, but then you realised you wanted to pursue your other interests, especially in public health. You did work a few years or many years overseas, and this kind of leads into our second question. How have your experiences working as a doctor overseas influenced your professional identity and practices back here at home?
Yeah, I think they're so diverse, so broad, and challenging in lots of different ways in terms of opening up the view of health and wellbeing, opening up the view beyond Victorian borders or Australia's shores, to really understand that there is this complex interplay of so many things in our lives, now fashionably called the social determinants of health, which I didn't know at the time, but you absolutely reflect on especially when you're working in developing nations and fragile states, of which Afghanistan is clearly one. Ethiopia was, and East Timor. So countries that really have health systems that struggle in lots of ways, and challenges that are really profound because they're both infectious disease struggles, but struggles that relate to poverty, to civil conflict and displacement, and elements that are really emblematic of inequality within those countries, whether it's gender inequality, whether it's marginalisation by virtue of religion or culture or language. They were at play in many of those places that I went to, indeed all of them. And so, you know, lots and lots of reflections on those broader components that certainly I didn't reflect on that much going through medicine. It was much more seen in a almost a mechanistic way about the human body and human physiology and you know, the workings of antibiotics and some of those technical interventions. But the more you see those broader elements play out in people's lives and livelihoods, the more you see that they have a really profound impact on our lives wherever we are in the world. And so I think it's really shaped that broad thinking about the determinants of our health that are often invisible, not always the purview of a clinician to manage, but I think should always be in their mind in terms of sitting there in the background and having that profound influence.
And now, Brett, I've got to have a throwback question now. So you were a previous student at the Melbourne Medical School, graduating in 1993. Could you quickly tell us a bit about what medical school was like for you?
Oh, wow. I haven't thought much about medical school. I think one of the real reflections is that I didn't appreciate it as much as I should have at the time. Maybe that's the story of life. But it was, you know, it was so rich in so many ways. Learning was maybe the technical learning, and the kind of narrow focus of medical content was maybe the least component of all of the learning that went on. So, you know, lots of exposure to clinical stories. There is an enormous privilege that we can sometimes forget as clinicians about the way that we're led into people's lives and into people's stories. You can sit down with a complete stranger and they will tell you something that they wouldn't tell anyone else in any circumstances. And so just to have that experience of and privilege of being led into people's lives, I think broadened my view of so many things, and I didn't appreciate it as much as I might have at the time. I also didn't appreciate the kind of freedoms and richness and diversity that I came across in medical school. Having gone to Melbourne High School, you know, select entry school, boys' school, and maybe a bit cloistered, it was nice to have the fulsome experiences of medical school with all of that kind of new worlds opening up. And looking back now, I really do appreciate it.
Thank you for that. And thank you for sharing your wonderful experiences with us. I think I will hand it over to Ryan now, who will launch our second poll for the evening.
Hi, Andrew, could you just launch the poll for the next section?
I'm waiting for it to arrive.
So now we'll be moving into Brett's role as Chief Health Officer Victoria and his current involvement with the pandemic. So we'll just wait for the poll to load and then we'll get some of the...
Here we go.
Here it goes. And we'll just give it about 30 more seconds.
Okay, I'm going to close the polling now.
Yep.
It's not really moving. There we go. You should be able to view that.
Yep, thank you. So Brett, I've got a couple of questions here. Firstly, what does a Chief Health Officer do? and tell us a bit about a day in the life of a Chief Health Officer, both pre-pandemic and in the current pandemic.
Sure. Look, the current pandemic's pretty straightforward. There's just a long series of meetings and commitments that start very early in the morning and go until late at night. We've got a 7:30 command call with the State Health Controller, who's the Secretary of the Department, with all of the senior executives in the department, talking through all of the aspects of the response that they have stewardship over. So the testing, the communication and engagement, the outbreak response, elements in disability care, elements in aged care, the acute hospital services response, pathology services and innovations in testing, data management, case control and outbreak management, and all of the hot issues overnight in terms of clusters or outbreaks that have occurred. So we touch base on all of that. Everyone checks in on their hot issues and get tasked things to do for the day. And I'm there to kind of get a picture of those issues, my reflections on some of the responses, and to see what the numbers are for the day. And then, there's a state control meeting, which is the emergency management framed meeting for the day, with the Emergency Management Commissioner, again, the State Health Controller, but all the secretaries of the other relevant departments, transport, education, justice, and corrective services, and jobs, precincts and regions. So really high level, whole of Victorian government operational response priorities for the day. And we're really discussing the coordination of the whole of Victorian government response. And then I'm really prepping for that morning presser, where I get, again, what are the issues that have come up in media? What are the issues that we know are emerging? What are the numbers for the day? What do they mean? And are there any particular things to reflect on, or are there new policy announcements that I need to get across as well? As you know, the press conference can be an hour or, dare I say it, 2 hours. I kind of play it by ear. I don't do enormous amounts of preparation for that. I like to speak off the cuff. I think if I've got any role in that forum, it's really just to speak honestly and authentically to the questions as they arise, and to be straight up about what's working, what's not working, what we should reflect on, what we should do differently, and to try and get those key messages that I think are critical to getting us on the right pathway around testing, around isolating, around following the public health directions. But I do recognise that it's such a long haul, so need to try and bring some freshness to that space as well. But as a mechanism for kind of direct response to questions, I think it's an important one. Then there's AHPPC, which is the Australian Health Protection Principal Committee. So all the chief health officers, sometimes called chief preventive health officers or directors of public health across the country, with the Commonwealth counterparts, where we're talking all of the policy issues of the day. I give my epidemiology update to them, but we're also discussing aged care, disability, Aboriginal and Torres Strait Islander health in the COVID pandemic, and any other policy question or kind of epidemiology and response question that arises. And then, a bunch of other meetings with my team and all of the pillars in the outbreak management and testing and pathology and policy and strategy development, understanding that, we're changing the settings every few weeks. What do we need to write differently into public health directions based on the evolution of the pandemic? And then a kind of wrap up meetings towards the end of the day that finish at 7 or 8 or 9, depending on who I'm talking to, which is sometimes including the Premier and the Chief of Staff in Department of Premier and Cabinet, the Secretary and various other people. Pre-pandemic was very different. I guess I was mostly based 50 Lonsdale Street, much more engaged in the health protection branch. There was no COVID division. There was nothing coronavirus. And so it was on those three basic pillars of health protection, which the Chief Health Officer has ultimate responsibility for: infectious diseases and the 70-odd notifiable diseases, everything from syphilis to whooping cough to measles to Legionnaire's disease. Food safety, so that's foodborne outbreaks and food contamination events, as well as the general food safety elements that are, on the preventive side, keeping food safe for people to eat. And then environmental health pillar, which is cooling towers and Legionnaire's disease, managing radiation sources and any potential incidents involving radiation, and then environmental health policy and risk management. So that could be everything from a cancer cluster being investigated to issues with mold or issues with blue-green algae in our water team, and everything in between. So a lot of troubleshooting. It's very response focused. That's what health protection does. There are Chief Health Officers across the country who have a portfolio that is the population health and preventive health side more explicitly. But in Victoria, the Chief Health Officer role is much more in the health protection response side. But I do collate every 2 years a kind of snapshot of the health and wellbeing of Victorians. And so that's looking at a lot more of the population and prevention health measures that incorporate tobacco and obesity and screening services and child health and the like. But actually that's in a different branch that is managed separately to my role in health protection.
Thank you. And I just wanted to pick up on something you mentioned about facing the media every day. Ever since the pandemic's emerged, you and your colleagues have been sort of thrust into the public spotlight. I just wanted to ask you, how have you managed the criticism and admiration that has come with this?
Look, I guess I needed to have an expectation that in a space where you reach into the most intimate aspects of people's lives, their sovereignty, the private components of being able to leave their house or not leave their house, and constrain them in ways that are unprecedented, it is entirely appropriate for people to be passionate about that and to be vocal and to be critical or supportive. And so, I tell myself intellectually, people should and must be free to speak on how they're affected by that and how they feel about it. And there's always going to be an enormous divergence of opinion based on people's philosophical and political persuasions. I'm focused on public health advice to the cabinet of the day, but I understand that people will respond to that very positively, very negatively, and everything in between. I think it's important for everyone in public life to kind of separate themselves as a personality or as an individual from that commentary. My worth, if you like, is not measured by that commentary. It's not even measured by my colleagues' commentary to me or other friendly voices. We should all be measured on what is our great desire in the decisions that we make, and reflecting on the fact that we do it with the information and knowledge and skills and capacity that we have at the time. There will be mistakes made. There will be things that go awry accidentally, and we do need to separate ourselves from that, especially when there are such significant consequences. All you can do is be purely motivated to protect life and limb. That really is my role, and to do it with all of the teams around you, giving you the best advice that they possibly can, and you providing the best advice that you possibly can. But it won't please everyone, And as I say, some things will go right, some things will go wrong, some things will take an unexpected turn. But you've got to be on your game in terms of being pure in providing the very best unbiased advice that you can, and to be motivated by that public health dictum of protecting health and wellbeing, and let others provide that broader commentary on what it means for economy and other components that, as a public health physician, I have some insight into, but it is for the whole of Victorian Government and Cabinet to make some of those broader determinations.
Thank you. I'll now pass over to Ross, who will be telling us a bit more about your role as Chief Health Officer.
Thanks so much for your insightful answers so far, Brett. Before COVID, you were talking about the healthcare challenges that will come about with the climate crisis. Could you talk about that for us a bit now? What lessons does COVID have for this other pandemic?
Yeah, in many ways it looks very different, doesn't it? But I think there are really significant similarities. The primary one is prevention is better than cure. We are profoundly challenged by this pandemic because of the way that it reaches into every aspect of our lives and every component of societal functioning. But the response is costly. People are harmed in the response, even as we're trying to protect them from the harms of the virus. It is a very worthwhile investment to get yourself in the very best position, even for these relatively uncommon events that are global pandemics, if it means that you can mitigate some of the consequences. And so I would say make that investment in public health, not just for infectious diseases, but more broadly, because you will be well served by the robustness of the system that responds. I think we've done well in Australia, but I think it's a lesson across the world that your return on investment in public health is 10-fold or 20-fold or 100-fold, especially for a multi-billion-dollar consequences of a pandemic. For climate change, the lessons are similar. The Stern report out of the UK, the Garnaut report in Australia really speaks to the fact that there are costs here that are unavoidable no matter how you go about it. But in investing in some of the mitigations, both the mitigations of the consequences, but also mitigating the emissions, has a benefit for Australia and globally that again outweigh some of the after the fact responses if you're not investing in that prevention. The cost of emergency and disaster responses with rising sea levels, with extreme weather events, with heat waves, increasing risk of flooding, increasing risk of foodborne illness, of vector-borne disease. They are all expensive events. You can't tie each and every one of them to a specific rise in global temperatures or local temperatures, but we know that the probability of all of them increase slowly but surely and really inevitably over time, unless you can really invest in some of those significant mitigations. Australia on its own will not turn global temperatures around, but it's been said before that those of us who are in the 1%ers club make up, almost the majority of contributors to greenhouse gas emissions, and the investment in disaster resilience and some of the mitigations, knowing what's coming, because there's plenty of modelling around how things will go in Australia, and Australia is particularly vulnerable, and the southeast corner of Australia is even more vulnerable within Australia, that we really need to make that investment now, because those challenges will come to us inevitably.
Thank you for your very honest and frank answer. How do you believe we as health professionals should combat health misinformation?
Look, it's very challenging. I think we have to be as creative and innovative, thinking outside the box. You know, government is sometimes too traditionally and too conservatively framed in the way that we engage. We're pretty risk averse in general, but this is a challenge where you need to meet people where they are, and those people are going to all kinds of sources in all kinds of ways. And they're being really creative and innovative with their misinformation and their disinformation. And so we need to meet them where they are, which means going to all media, all modes, and really getting an understanding of how that information is getting around, how people are responding to it, why they're responding to it, and the ways that we can influence with correct information, with information that will support people's health and their well-being, and not put them at significant risk. And we need to recognise that the existential dangers of that misinformation. You know, when the difference in vaccination rates of 90% and 98% are really substantial, it can be the difference between clusters and outbreaks of disease and not having them. We do need to find each and every person, and we need to get to as broad a coverage and find those hooks that are both the content that is technically correct, but also the emotional engagement and also the human storytelling that is real and that people respond to. Again, we can be too traditional and say, oh no, that information is wrong. Here is the correct information. That is just not going to work for a significant proportion of the population. I don't think we should spend our efforts on the real deniers in whatever space, anti-vaxxers, kind of deep state conspiracy theorists. They will not be turning. But there are people around them who are influenced by the strength of their voices, and we need to play in that space in order for them to be exposed to right information and to be influenced by it with the same kind of strength that those real deniers can also use, because they know what's influential, and they're working very hard to influence in the wrong direction.
Last question, how do you think or hope the health system will change in Australia after this pandemic?
Look, it's always a hard guess. There are some classic responses sometimes, again, of government in response to something which throws itself to the response elements. I would hope that there are really deep reflections on the prevention, preparedness side as well, that we shouldn't just think about how we structure in terms of our agility in responding or some of the strength of the response elements, although I would hope, and I think that we need to go to that, but also to the agility, the robustness of the prevention space. And for me, in coronavirus, and it applies in climate change, it applies in lots of other threats to health, the issues of equity within society are key there. The social determinants of health are the ones that play out in how people are affected in disasters, in really significant health challenges. And so, the issue of casual mobile labour has come up with coronavirus, and how it's really been a contribution in terms of the insecurity of people's work and being forced to go to work with symptoms or with very vulnerable members of the community. I think that's clearly an area to look at. There'll be other areas that relate to this pandemic that we should look at. Homeless people were clearly a vulnerable group. We have come up with a response to protect them, and we should reflect on that as a sustainable response, or what are the lessons for a sustainable response to the issues of insecure housing and homelessness in Victoria and more broadly. So I think there are probably 1,000 lessons. I hope that they're all dug into in the broadest sense to provide lessons for this and for other challenges.
Okay, Brett, just one last question on this topic before we move on to well-being. What in your, as will be future health professionals, what in your eyes are some of the important health issues that we'll have to encounter when we become doctors?
Yeah, I mean, the big ones are pandemics. I think they'll be more common. They've kind of averaged every 25 years over the last couple of centuries. But with the encroachment of urban spaces on wilderness areas, with wet markets being a reality around the world, with population increases, and with the global movement of people, they may well occur every 10 years, God forbid. But we'll need to really think about how to reduce the risk of them occurring, but also that early response to try and stop them becoming pandemics, and if they are pandemics, to try and minimise their consequences as well. But infectious diseases and emergent infectious diseases more broadly are kind of the counterpart to pandemics, and zoonotic diseases arising in animals that affect humans. They make up 3/4 of emerging infectious diseases in the world. And whether or not they cause pandemics, they can cause really significant challenges globally. Ebola, Hendra, Nipah virus, Marburg, Lassa fever, the list is extensive. And some of them, again, do not become pandemics and aren't always human diseases, but can be really challenging anyway. West Nile virus, equine influenza, a whole bunch that we need to think about in the One Health paradigm, the interaction of environment, our food system, our animals, and human health. Antimicrobial resistance also kind of plays in the One Health space, the intersection of antibiotic use in our food production, in our animal husbandry, in human use at the pointy end in intensive care units, but also at primary care level. So also needs really broad systemic considerations around how we meet that challenge, which is a challenge of surveillance, of integrated response, of good data management, of understanding human behaviour change and behaviour change communication, and the enabling environment to help people make the right choices with antibiotics. There are no easy technical solutions in some of these areas. We often hang our hats on the vaccine or the new antibiotic, but they really are complex, wicked problems that need multi-dimensional considerations of the response. Climate change, we've talked about, it's a genuinely existential threat to our well-being. Whether 2020 will be a significant year in terms of a fire season in Victoria. Again, our reflections need to be on what the probabilities are as they change over the long term, and how much of a lead time we need in terms of trying to get some of those mitigations in place, because it'll be 2035 before we're turning things around, even in terms of getting to some of those thresholds or milestones that we've talked about with our carbon emissions. But it'll be an even longer period before climate turns around. And so we've got literally decades of more challenging climate ahead of us. So we need to think in the long term. Look, the list is very long. There are significant demographic, technological, human behavioural challenges as we go through this century, as population increases, as urbanisation increases, as environmental degradation is a really significant challenge. We need to reflect on an ageing population, a mobile population, a technologically embedded population, and not just see it as challenges, but as also significant opportunities to support our health and well-being.
Okay, thank you. I think we'll move on to the well-being section. So Andrew, if you can start the poll. So this section is mostly about how to deal with stress, how to balance work life, which I would imagine the pandemic has thrown a wrench in. So yeah, submit your questions.
This is where the elevator music is required.
That's right. Well, Steve had a bit of Creedence Clearwater Revival on earlier on, so
These guys won't know who.
no, they won't.
Clearwater Revival.
No, wouldn't have a clue. Okay, looks like we've reached a static with the polling. I'll end the polling.
Okay.
There we go.
Okay. Oh, the most popular question. Okay, so about coronavirus. It's been really stressful on your job, I imagine. So how do you de-stress and unwind at the end of a busy day of press conferences and talking to medical students?
Look, it's a genuine challenge. I don't have all the answers. I can tell you what I try to do, what my family reminds me that I should be doing. And for me, there are really four pillars. Try and get good sleep to the best of your ability. Get some exercise in of whatever kind. I try and go for a run. If I don't go for a run, I absolutely go for a walk. If I can't go for a walk, I absolutely try and get outside, take my calls, take my computer, just sit in the back veranda and hear the sulphur-crested cockatoos that are around my place, and get some fresh air. Eat well, again, seems like a small, maybe inconsequential thing, but there were times there when I was doing all three of those things really poorly, not sleeping much at all, not exercising at all, and virtually either eating absolute rubbish or not eating much at all. And the fourth one is finding that time for yourself. So whether that's meditation, for me it's meditation, but it could be, progressive muscle relaxation or a hot bath, or time out, handing your phone to a colleague even in the course of a working day and saying, look, please take any urgent calls. I'm going to check out. I'm not going to look at emails. I'm not going to look at text messages. I'm not going to receive any phone calls. And I'm just going for some me time for half an hour. So compartmentalizing your day to manage that, I think, is really important, especially when, I've been going since 26th of January, almost every day. I do get a day off a week now, which is my Thursday when I get covered, which is terrific, but it's still a 6-day week and there's still 12+ hour days easily. And so, part of it's recognizing that there's no easy escape. Like, I've got that responsibility. I have to step up, and I need to ready myself for some weeks or months more of this pace, but to ready myself for that by not going crazy each and every day. So carving out that 1 day a week has been a more recent thing that I've gotten into place. I will try and take a few days of leave. I am looking at compartmentalizing my day for that time to try and unwind, and talking to my family and focusing on home well-being is really critical as well. I've got 3 gorgeous kids, gorgeous wife, and they are my absolute rock, and I need to recognise just how supportive of well-being, venting, chatting, focusing on something that isn't work but is their schoolwork or craft, or having a glass of wine with my wife are really important things, and can't be discounted in terms of supporting your well-being. It's that oxytocin effect of cuddling your children that shouldn't be discounted. It really brings positive endorphins to one's life. And I talk to, I've spoken to a psychologist about strategies for managing stress as well, because there are those 4 pillars that you can do to manage the stress of the day, but there is a responsibility that is inescapable around the deaths that I know are occurring, and the hardship and the suffering and the physical and psychological consequences of the choices that I'm making as well. That is an inescapable responsibility, and you can't just meditate that away. It's not an acute stress in the same way, and it's not dealt with in the same way. It really is dealt with by talking through all of those more nuanced strategies that you need to put in place. And so, yeah, if there's anything I could say to anyone, it is okay not to be okay. If you guys will be suffering with the rest of Victoria and Australia in whatever way through all of the challenges of this pandemic. You should recognise that you may struggle at times in your work and study and home life, and you should recognise that you need to reach out to others if you are struggling. We wouldn't stop someone with a broken arm getting a cast. We shouldn't stop someone who's struggling with anxiety or depression or anything in between from reaching out for the appropriate help. So it's also getting over that stigma and being clear that none of us are superhuman in this space, and anyone can come to struggles no matter who they are. And there are many around us who are ready to support and love us, and we should recognise that.
Thank you. So just sort of following on from that previous question, as you'll know, medical school can be a really challenging time for students, and especially right now. What are your thoughts on medical student wellbeing and mental health?
Yeah, look, it's clearly a challenge. It's one of the toughest courses that you can go through. It can be relentless in terms of the volume of stuff you have to get through for the purpose of learning and exams and assignments. I think we should always remind ourselves intellectually of what the important stuff in life is. Sometimes it takes a lot of that intellectual habit forming in our internal monologue to remind us that the world doesn't hang on this one day, this one exam, or even this one year. And we need to have that positive voice in our heads that, our happiness in life, and in many respects our success in life, is going to be broader than being a doctor or not being a doctor, or being a first class honours student or just a pass. We need to put things in their appropriate context. Everyone will be doing their absolute best, but they shouldn't do it to the detriment of the whole being. Again, if you had a gangrenous leg, you wouldn't let it take over your whole body. You would manage it in its place, and whatever aspect of our life that can really be stressful needs to be put in its place in terms of a context and a recognition that our success and our well-being and our worth as individuals goes beyond one dimension.
Yeah, thank you. It's some really great advice. And just to wrap up, do you have any sort of final pieces of advice for us as medical students today?
Do public health. Look, I would say think about public health, whatever you do in life, whether you're a microbiologist, a radiologist, or a psychiatrist. Public health is about the health of populations locally and globally. It is about all of those things that come together in a really complex way to determine how we do as human beings. And there are really powerful interventions that can be made that we don't recognise. I think that the campaign to end smoking in Australia has been extremely successful, and we're world leaders there. That has probably saved more lives than any one of us will ever do in our clinical life ever. And so if you can think about public health in that broad context, and whatever you're doing, have a consideration about what ways you can reach into population health. I think that's a really valuable lesson.
Thank you for that. I'll pass back to Lisa now.
Thanks.
Thank you so much, Brett. I think that's an important message you've shared with us today. And I think Ryan, who's doing his MPH right now, is very pleased to hear that. I think that's all the questions we have time for today. Thank you so much to all the students and staff in the audience for tuning in tonight and listening to our discussion. I would also like to thank our lovely student panel, Ryan, Ross, Raymond and Olivia, and also thank you to Dr. Andrew Baird and Professor Steve Trumbull and Steve Martin for their support behind the scenes in organising this webinar. And last but not least, I'd like to thank Brett for taking his time out of his busy day to share his experiences and his insights and his wonderful advice with us today. It's been an absolute privilege to have you here.
Great.
Thank you all so much. It's been my privilege to connect.
Okay, thank you very much indeed. And I'll just really reinforce Lisa's comments. I can't really express them any better than Lisa, but to thank Brett very much for the insights and reflections on his career and his role. We've covered a lot of interesting topics. Brett would be horrified to know that there are about 100 messages in the chat, so which we haven't really been able to address, but there's been a lot of interest generated around Brett's role and Brett's career. So to everyone, to our medical students, to the panel, to Brett and to Steve Trumbull, thank you very much for attending. Thank you for taking part. I'll wish you goodbye, take care, stay safe, and good luck. Thank you very much, everybody. Thank you.
Thank you.
Thank
Thanks
you.
all.
Thanks, everybody. Thank you, everybody.